Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Welcome to the American Academy of Oral Surgery 2020 Global Summit. The Academy was built on principles of education, knowledge sharing, and enabling dental professionals to be better equipped to provide office-based oral surgery procedures to their patients. We understand that oral surgery is a field of study and a discipline of many in the profession of dentistry. There are over 2 million undertrained, licensed dental professionals and over 3 billion underserved patients worldwide. Oral surgery is there not just for any specific specialist, but for all licensed dental professionals from around the world who wish to learn or perform it. In the United States, licensed dental professionals are regulated by regional dental boards in each state. Dental associations and special interest groups have no legislative or regulatory privileges to prevent licensed dental professionals from performing oral surgical procedures. It's about knowledge, experience, and proper training to keep our patients safe and happy. Let's find ways to minimize the effect of the silent epidemic, maximize information exchange, and enable our colleagues to better serve their patients worldwide. As you can see to the right of the screen, we will be airing the 21 academic sessions on Facebook's Global Summits page. Simply visit the page at Global Summits, and the live session will be pinned to the top of the page. Click in and you will have access to the presentation, which are complimentary to watch. At the end of each session, at the end of each 1-hour session, there will be a link in the comments section that you can fill out to register for CE credits. The link will disappear after 30 minutes. There's a nominal fee for receiving a CE certificate, but attendance and watching the sessions are complimentary. Today, you will be able to meet certain license requirements pertaining infection control, OSHA, HIPAA, and also COVID precautions at our pre-symposium kickoff virtual workshop event. It starts at 1 p.m. Pacific Standard Time. You will be able to earn up to 24 CE units by registering when the courses are live. 4 CE units will be attainable today. Tomorrow, we will kick off the general session with our keynote speaker, and we will be live all day from 7 a.m. to 6 p.m. Pacific Standard Time. 10 CE units will be attainable. On Sunday, we will be live from 6:30 a.m. to 6 p.m. Pacific Standard Time. Another 10 CE units will be attainable for a total of 24 CE units. As a token of appreciation of you getting more involved with oral surgical procedures and or expanding your existing knowledge, we will extend a 1-year membership in the Academy, valued at $500, and a 1-year membership in Dentulu, the revolutionary teledentistry marketplace, valued at $2,500, complimentary to you. Simply use the code Global Summits on aa-os.org or dentulu.com when registering to redeem this special offer. Thank you, and let's have a great Global Summit together, as we like to say, doctor to doctor. Thank you. Good morning, good afternoon, and good evening, friends and colleagues from across the world. Thank you for joining us today for the 2020 Global Summit of the American Academy of Oral Surgery. We had a robust pre-symposium course yesterday with OSHA, HIPAA, and also COVID precautions and infection control. We're going to start our day with our keynote speaker, Dr. Timothy Ricks, and I will be making an introduction very shortly. Just a couple of housekeeping things. You will have the ability to register for CE. At the end of every 1 hour course, there's a link on the bottom that disappears after about 30 minutes. So you have about 30 minutes to go in and sign to get your CE certificate. All of the 20 remaining sessions are of an academic or informative nature. And particularly, our keynote speaker will be speaking about the forthcoming General Surgeon's report on oral health. But to get going in the day today, let's get started. I want to make a quick introduction to Dr. Timothy Ricks, MPH FICD. He is currently serving as the 19th Chief Dental Officer of the U.S. Public Health Services, as well as the Assistant Surgeon General of the United States. He serves as the Surgeon's General spokesperson on oral health and interacts with chief dental officers from other countries, with military chief dental officers, with leaders in organized dentistry, with state oral health programs, and much more. In fact, every time I look at Dr. Ricks's programs that he has going on, he's in a different room informing and advising other groups such as ours. He's currently overseeing the development of the second ever Surgeon's General Report on Oral Health. In addition to his role as the Chief Dental Officer, Rear Admiral Ricks served concurrently in numerous national roles within the Indian Health Service, including Continuing Dental Education Coordinator, Oral Health Promotion Disease Prevention Consultant, Oral Health Surveillance Coordinator, Dental Lead for the Government Performance and Results Act, and IHS Representative to the Healthy People 2020-2030 Oral Health Work Group. So Dr. Ricks, knowing Dr. Ricks, a lot of his career started in the Indian Health Services, dating back to dental school. Rear Admiral Ricks has served in the U.S. Public Service for over 20 years. Prior to his service, he was an associate dentist, independent contractor, and sole proprietor, and he has also served as a military police officer in the Army National Guard. He has served in numerous leadership capacities within the U.S. Public Health Service, led multiple national initiatives, and is the recipient of numerous USPHS and IHS national awards. Dr. Ricks holds a Bachelor of Science degree from Delta State University, a Master of Public Health degree from the University of Nevada, Reno, and received his dental degree from the University of Mississippi, where he spent quite a bit of time. He completed a dental public health residency with the Indian Health Service and is a board-certified diplomate of the American Board of Dental Public Health and a fellow of the International College of Dentists. As you guys know, in the U.S., dental public health is actually a specialty now. And we're very honored to have him. He's going to give us a very thorough discussion about what is upcoming in the Surgeon's Report. And also, he's a professional that exemplifies of what's possible, being in the private sector, government sector, having been involved with the educational sector, and on it goes. I highly urge you guys to tune in and enjoy this show. With that said, Dr. Ricks will have the floor. Thank you so much. We're honored to have you today, Dr. Ricks.
Thank you very much, Dr. Shaw, and good morning, good afternoon, good evening. Thank you for the opportunity and the honor to speak to all of you today at the American Academy of Oral Surgery. The U.S. Public Health Service, whom I represent, values our partnership with AAOS, and your president, Dr. John Robertson, actually was a classmate of mine a few years ahead of me at the University of Mississippi Dental School, and I'm glad we recently reconnected because he helped me get through dental school many years ago. So again, I'm very honored to speak with you, all of you today. So here's an outline of what I'm going to discuss today. I'm going to give you an overview of the U.S. Public Health Service, who we are, what we do. I'll talk about that first ever Surgeon General's report back in 2000. I'll talk about issues that affect oral health across the world now and in the future. I'll briefly talk about our forthcoming second ever Surgeon General's report on oral health. And since it's the topic of the day, topic of the year, I'll briefly mention the impact of COVID-19 on oral health. And I may have time for questions, may not, but I'll give you my contact information if I'm not able to take questions. As far as the disclosure, I have no financial interest in anything mentioned during this presentation. And where appropriate, I have referenced sources to the information that I've provided. So the first thing I want to do is give you an overview of the U.S. Public Health Service. Our motto is in officio salutis, which we interpret to mean in the service of health. So we were formed over 200 years ago in 1798. We're one of 8 uniformed services in the United States, which includes the Army, Air Force, Navy, Marines, U.S. Coast Guard, the National Oceanic and Atmospheric Administration, the U.S. Space Force, and the U.S. Public Health Service. We are an officer-only corps. We have no enlisted people in the U.S. Public Health Service, and we consist of health professionals, dentists, physicians, nurses, plus people allied health, engineers, environmental health officers, dietitians, people like that. We're led by the Assistant Secretary for Health. Our current Assistant Secretary for Health is Admiral Brett Giroir. And we are operationally led by the nation's doctor, the U.S. Surgeon General, and our current Surgeon General is Vice Admiral Jerome Adams. This picture here on the right shows a photo of officers being deployed to Africa for the Ebola response. So we deploy worldwide, the U.S. Public Health Service does, and especially in the midst of this ongoing pandemic, we have deployed across the country and across the world to help with the pandemic response. We also deploy in times of natural disasters such as hurricanes, with our most notable deployments in 2005 following the hurricanes Rita and Katrina that devastated the U.S. Gulf Coast. And we've also deployed in times of man-made disasters such as the 9/11 terrorist attacks. Dental officers in the U.S. Public Health Service serve primarily in 3 different departments. Within the Department of Justice, we have dentists that serve in over 100 federal prisons across the U.S. Within the Department of Homeland Security, we have dentists that serve in 26 U.S. Coast Guard stations across the U.S., as well as over a dozen Immigration and Customs Enforcement Health Service Corps stations located in several border states. Primarily, though, our dentists serve in the Department of Health and Human Services and serve in agencies such as the Centers for Medicare and Medicaid Services, the National Institutes for Health, the Centers for Disease Control and Prevention, the Indian Health Service, the Health Resources and Services Administration, and the Food and Drug Administration. Operationally, the U.S. Public Health Service dental program, we interact, as Dr. Shaw mentioned, frequently with external stakeholders. Globally, we connect with the World Health Organization, the Pan American Health Organization, the International Dental Federation, and what we call our Five Eyes colleagues of Canada, New Zealand, Australia, and the UK. We also connect with regulatory agencies such as the American Association of Dental Boards, the Occupational Safety and Health Administration, the Food and Drug Administration, and others. On the federal side, we are connected and collaborate with our military partners and with all of the federal agencies I mentioned previously, and with the different disciplines within the U.S. Public Health Service. And then our biggest group of external stakeholders are organized dentistry and public health organizations, such as the American Academy of Oral Surgery. So let me switch gears. I'm first going to talk about the 2000 Surgeon General's report. So it's really important for you, those of you not familiar with the U.S. Surgeon General. The U.S. Surgeon General is the nation's doctor, and Since 1964, which began with a groundbreaking report on smoking and its consequences on health, the U.S. Surgeon General has distributed 62 reports, and these reports set forth national priorities and calls to action, and inform the world. Actually, half of those reports have been on tobacco or smoking related conditions. But the first ever report on oral health was released in 2000 by then Surgeon General David Satcher. It was entitled Oral Health in America, and this is a picture of the front cover, and it had as its major message that oral health means much more than healthy teeth, and it's integral to the overall health and well-being of all Americans. And in fact, what it made the statement, you cannot have overall health without first having oral health. Now, research had been done for many years prior to this report, when it was released in 2000, that showed some of the associations between oral disease and systemic disease. But this report is often credited with elevating that conversation and getting our non-dental colleagues to really understand the relationship between oral health and overall health. With such a great laid out plan, and there was a follow-up call to action in 2003, you would think that many of the problems of oral health had been solved across the world. There's been significant investment, as we know, in research and in practice. But as recently as 2016, the burden of oral disease still persists. The Lancet, which is a publication from the UK, lists the top disease burdens. Out of 328 different disease conditions, 4 of the top 30 were oral health related, with untreated dental caries in permanent teeth being the #1 global disease burden. Here's some key facts from the International Dental Federation that I think are important to kind of ground us as we move forward. First of all, 44% of the world's population has untreated dental caries. And as I mentioned, untreated dental caries in permanent teeth ranks as the #1 disease burden globally. 60 to 90% of school children worldwide have had caries experience. 15 to 20% of 35 to 44-year-olds have severe periodontal disease, as indicated by a periodontal screening and recording or community periodontal index score of 4. 30% of seniors between 65 and 74 years of age have no natural teeth. Oral conditions are the 4th most expensive to treat, and then related to dental caries, worldwide sugar consumption has tripled over the last 50 years. So that sort of sets the stage for what I'm going to talk about now, and that is different issues that affect all of us now over the last 2 decades and moving into the future. And I put this picture of a newspaper from 2000 just to remind us that at the beginning of this century, we were all worried about Y2K and how that was going to shut down our computers worldwide, but that did not happen. But we do know that this digital age has really affected how we conduct business, how we do business. And there are other issues as well, including oral health disparities, the aging population, workforce changes, mental illness and substance abuse and their relationship to oral health, expenditures, emerging public health threats as we're seeing, and advances in research and technology. And I'll touch on each of these. So let's start with oral health disparities. And I like to say it's really inequities because there is a segment of social injustice when we talk about this. Now, this is just U.S. data from the Centers for Disease Control and Prevention. But what I want you to do is draw your attention to the 3rd, 4th, and 5th rows initially. And if you look at the prevalence of disease across age groups, different diseases, untreated decay, caries, experience tooth loss, you will see that in the U.S., Black non-Hispanic Americans and Mexican Americans suffer 2 to 3 times the rate of disease, the prevalence of dental disease, as do white non-Hispanic Americans. And then I want you to draw your attention to the bottom 2 rows, and those that are living at or below 200% of the federal poverty level in the U.S., which is currently around $25,000 for a family of 4, suffer disproportionately from dental disease as well, compared to those in the middle class that are living at or above 200% of the federal poverty level. So clearly we have a lot more work to do to try to eliminate oral health inequities in the U.S. And I'd be remiss if I didn't first or mention in that same context that oftentimes we think about disparities, but we don't look at the underlying factors. And there are numerous social determinants of oral health that we need to keep in mind as we look to improve oral health at a population level. There are individual determinants, socioeconomic status, behavior, smoking, chronic diseases, familial determinants, especially when we're talking about family support systems, and then social determinants. There's the educational system, there's housing insecurity, food insecurity, job insecurity. All of these things factor into a person's overall health and their oral health as well. And we need to address those things as we move forward. We can't look just at oral health. So next, I want to talk about a really important emerging factor, and that is the aging population. This is really an unprecedented challenge to all of us. And this, I'm showing U.S. data. I know that we have some friends that are joining us globally, but all of the data I'm going to be presenting today is U.S. only. But in the past 20 years, we've seen a 60% increase in the number of adults aged 65 years and older in the U.S. And by 2030, we will have more than double the number of adults over the age of 65 compared to 2000. And to put this into perspective, just in the U.S., if all of the adults over 65 held hands from the current population of 54 million over 65, they would circle the globe twice at the equator. Or to put it a different way, if they were all to move to the 25 least populous states, they would exceed the population of those states. And, you know, I should go back. Part of that is advances in science, where we've seen the average life expectancy go from 68 years of age for women, or with women at 71 and men at 66 back in 1950, to 78 years of age in 2010, 81 for women and 76 for men. And we've also seen the baby boomers, those born between 1946 and 1964, prospering because of the advances in healthcare and so forth. Another thing that's important to understand about the aging population is that by 2035, for the first time in the history of the U.S., we'll have more adults over the age of 65 than under 18, children and adolescents under 18 years of age. And this is really important because if you think about the investment that we make in prevention and early intervention of disease in oral health, especially in children and adolescents, you'll see that we do not invest nearly that amount with older adults. So this will be a driving force as we look into the future. In addition, economists use something called the dependency ratio. And this is a ratio that looks at the burden on working adults to take care of the non-working adults and children. So back in 2000, we had 20 older adults for every 100 working adults, and the purple indicates the older adults, and the blues are the youth that are 16 years and younger. Today we have 100 working adults now taking care of 28 working adults on average, but by 2040 it will more than double to 100 working adults taking care of 38 non-working adults over the age of 65. And what economists predict is that this is going to put a significant burden, this doubling of the impact, the dependency ratio, is going to put a significant burden on things like retirement, pensions, schools, disability, and other social programs. And this is not unique to the U.S. This is a worldwide problem as we move forward. So we have to think as oral health professionals, how will this affect the care that we provide to our patients? We also know that with an aging population comes additional healthcare expenditures. So on average, the number of conditions, many adults over the age of 65 have as many as 5 chronic conditions, and the per capita cost of that are more than $12,000 a year. One interesting thing that we've seen with older adults is that there has been improvement in the number of teeth that are retained. So, but it's differed greatly by income. So if you draw your attention to the light blue, which is poor people, and the dark blue, which is the non-poor, and those are the terms that were used by the researchers, what you'll see is that if you look at functional dentition, those that have 21 or more teeth, you'll see that back in the period of 1988 to 1994, around 18% of the poor had a functional dentition, compared to about 38% of the non-poor. If you fast forward to the period of 2009 to 2014, using the same criteria, what you'll see is both groups improved significantly. The poor went from about 18% to about 25%, and the non-poor went from 38% to about 67%. However, and I've highlighted this in the yellow, what you'll see is that the disparity, the difference between the non-poor and the poor actually has more than doubled. So both groups are improving, but those at lower income are not improving at the same rate as those at higher income. The final thing I want to talk about with an aging population is that more low-income seniors report their oral health as poor or fair. So if you look at this, 44% of low-income senior adults report their own oral health as poor or fair, compared to just 15% of high-income senior adults. Financial considerations and chronic diseases that begin in middle age and worsen as people get older are two of the major barriers to healthcare and oral healthcare. And the aging population over the next 2 decades will magnify these problems even further. All right, I'm going to change and talk about a changing workforce at this point. In the U.S., the Health Resources and Services Administration, or HRSA, designates what are called health professional shortage areas. They do this for primary care, mental health, and oral health. What you see in this map, the gray shaded areas are so-called dental health professional shortage areas, or HPSAs. And you'll see it's primarily rural areas. These are the so-called dental deserts. And 58 million people are living in these areas where there's not easy access to dental care. HRSA also recommends that if we were to remove this designation, we would need about 10,000 practitioners to provide care in these rural areas. And in fact, in the U.S., in the nation's 66 dental schools, we've seen a huge increase over the last 2 decades in enrollment and graduates. And in combination with the fewer dentists or more dentists delaying retirement pre-COVID times, we've seen a 22% increase in the workforce of dentists in the U.S. However, we've also seen a huge increase in population growth. So if you look at it in the context of population growth, there's only been about a 6% increase in the number of dentists per 100,000 population. In addition, one of the driving factors in where dentists practice immediately after dental school is dental school costs. The average educational debt for the class of 2019 was $292,000, according to the American Dental Education Association. And 4 out of 10 had debt in excess of that. And if you look at the payback over a 25-year period, that equates to about $700,000 in total. And this really drives where new dental graduates go. Very few are going back to rural areas just because of that significant debt burden. And in fact, if we look at rural areas, we see the impact of this problem. We see that almost 10% in rural areas are less likely to access dental care compared to urban areas. 5% of children are less likely to receive preventive services in rural areas compared to urban areas. 7% of adults living in rural areas are more likely to, adults living in rural areas are 7% more likely to be missing teeth and 4% more likely to have complete edentulous. And we also know that older adults are less likely to go to the dentist if they live in rural areas as well. We've also seen a change in workforce models in the U.S. 25 years ago, we saw 2 out of every 3 dentists were in solo private practice, and this has really dropped down to about half of the dentists now. And both of these graphs are courtesy of the American Dental Association's Health Policy Institute. The graph on the right, the pie graph, shows that now what we're seeing are more and more dental support organizations or corporate dentistry that have moved in, and about 8 to 10% of dentists now are working in these corporate practices. Many have moved into group practices, taking after the medical model, and there's only a few still left as sole proprietors. Because of the access issues in rural America, and especially in the most vulnerable and underserved populations, we've seen the rise of different alternative workforce models. We've seen a rise in expanded function dental assistants, independent or collaborative practice dental hygienists, community dental health coordinators, community health aides, and dental therapy. And just to give you a little history, dental therapy began in 2000 in the U.S. It was imported from New Zealand and began in Alaska, with the first graduates coming out in 2004 and going to the remote villages in Alaska. In 2009, Minnesota became the first state to authorize dental therapy, and now there are 12 or 13 states that have authorized some version of dental therapy. Next, I want to talk about mental illness and substance abuse. So these are 2 separate facts, but I wanted to put them on the same slide just to make a point. Teenagers, 765,000 teenagers had mental illness in the U.S., according to the Substance Abuse and Mental Health Services Administration. Upwards of 60% of adolescents in community-based substance abuse treatment programs also met diagnostic criteria for another mental illness. At the same time, and not completely unrelated, Dentists are the top prescribers of opioids in the 10 to 19-year-old age group. The only reason I bring up this point is this is a very vulnerable age group anyway because of the prevalence of substance abuse and mental illness. And we do know that because of third molar extractions, dentists are prescribing opioids. As the number of opioid prescriptions has risen, we see that there has been a significant rise in this period of 2010 to 2015. It was about a 65% rise in the number of prescriptions written by dentists. And in fact, 29% of all prescriptions written by dentists were opioids. And we prescribed 18.5 million prescriptions in 2015, but there were 64 million written each year, other prescriptions written by dentists. So it's really not the largest thing we do. And the American Dental Association has noted that over time, we've seen a dramatic decrease in the number of opioid prescriptions written by dentists, from being 15% of all opioid prescriptions in the U.S. to now just in 2012, 6.4%. And as we talk about opioids, I think it's important in the U.S. to describe the three different waves. We really had the prescription opioid wave of opioid overdose deaths starting in the late 90s, and it's kind of leveled off, as you can see from this graph. The second wave was heroin, and this is notated by the gold line here. And we saw an increase beginning in 2010, but that too has kind of leveled off. The third wave began kind of in 2013, and that is the synthetics like fentanyl. And we've seen that really skyrocket since 2013. And this actually prompted our U.S. Surgeon General to issue an advisory. An advisory is something short of a report. It's kind of a warning to Americans. And basically, the Surgeon General of the United States, Vice Admiral Adams, said that we as healthcare providers should absolutely make sure we're carrying naloxone, and that friends and family of those who have a history of opioid use or overdose should also have naloxone. And in fact, the Surgeon General, if you go to surgeongeneral.gov, the Surgeon General has infographics and postcards that you can print out and give to patients or family members about opioid misuse. And this is one such thing. As we talk about mental illness, let's talk about adults now. So there are 45.6 million adults, or 18% of the population, that have reported mental illness in the past year, and 6.7 million adults report illicit drug dependence or drug abuse. Methamphetamine, which was once just a curse apparently of rural America, is now experiencing a resurgence, or maybe it never went away. Maybe it was just hidden by the opioid epidemic. But it has a direct consequence on oral health, as many of you have seen. And meth users have twice the number of decayed, missing, and filled teeth as non-meth users. Prescription overdose deaths for opioids skyrocketed as well, from about 8,000 20 years ago to 48,000 as of 2017. And I don't have this graphed out, but in 2018, we saw a decrease for the first time in opioid overdose deaths. So now let's shift gears. We'll talk about healthcare expenditures. And I want to compare us to some other countries first. Healthcare expenditures, and this is not oral health, this is general, but healthcare expenditures are a major concern. The U.S. spends over $3 trillion a year in total healthcare expenditures, and this is more than 5 times what China spends, and China has 4 times as many people as the U.S. A significant portion of overall global healthcare expenditures is accounted for by the U.S. And in fact, if you look at per capita spending on healthcare, per capita healthcare expenditures in the U.S. exceed $10,000 per year. And this graph shows a bunch of different countries, industrialized countries, but what you'll see in the far right is the U.S., and we far exceed every other country. Dental services account for about 4% only of total healthcare expenditures. But what we've seen is dental expenditures is one of the primary drivers of access to care. According to the American Dental Association, total dental expenditures have more than doubled in the past 25 years, going from about $60 billion in 1990 to $120 billion in 2016, and that's adjusted for inflation. Per capita dental expenditure, which is what this graph shows, has increased from $232 in 1990 to $413 in 2018, almost double. This graph is also courtesy of the ADA. Because of these increased costs, dental care consistently ranks at the top in terms of people foregoing care because of costs, with almost twice as many Americans foregoing dental care due to costs as those who didn't get their prescription drugs, medical care, or optical care due to cost concerns. And the bottom line on this is, for many Americans, dental care is still considered a luxury. And in fact, if you look at us compared to other countries, you'll see this. So the map on the right shows the prevalence of dental diseases, caries, perio, etc. And you'll see that the U.S., Canada, several African nations, China, etc., have a very low prevalence. But if you look at the graph on the left, what you'll see is that more people are willing to skip a dental checkup or dental care because of cost and concerns in the U.S. than any other country in the world. So next, what I want to do is talk about some emerging public health threats. And the first thing, if we were in person, I'd ask you to raise your hand if you could name the top HPV-attributed cancer. And most people would say cervical cancer. But several years ago, oropharyngeal cancer surpassed cervical cancer as the top HPV-attributed cancer, as I've outlined here, with males having the highest incidence. And as oral health professionals, we have an important role in educating our patients. And in some states and jurisdictions where they've been authorized, dentists can actually give HPV vaccinations. And in the U.S., just for your reference, HPV, the vaccine, Gardasil 9, has been approved for ages 9 all the way up to 45. So we should be educating our patients and parents about the HPV vaccination. Another emerging threat is the use of electronic cigarettes. This was originally designed as a tobacco cessation tool, but what has happened is not only did it fail in that regard, where we know that only 20% of current users are former cigarette smokers, while almost half are current smokers. So they're smoking plus using this. They're not actually quitting smoking because of it. But more alarmingly, what we've seen is that e-cigarettes have surpassed cigarettes as the most common tobacco medium for high school students. And in fact, this jump from 2017 to 2018 in the use of e-cigarettes prompted our Secretary of Health and Human Services, Alex Azar, and the U.S. Surgeon General, Dr. Adams, to issue the first ever Surgeon General's advisory on e-cigarette use among youth in December of 2018. And what you see from this graph is two things. First of all, if you look where I've pointed the arrow, about a third or 4 out of every 10 high school students in 12th grade have reported vaping or using e-cigarettes. What is alarming is that 1 of every 5 8th graders in the U.S. also report vaping. The other thing that is emerging is from the where I've got it boxed in on the right, is that more and more children, youth, and adolescents are using cannabis or cannabinoids in their e-cigarettes. Of course, the other public health threat to all of us right now is COVID-19. And so what we know is, in the US at least, in March of this year, March 17th to be precise, the White House Coronavirus Task Force Response Coordinator, Dr. Deborah Birx, recommend that hospitals and dentists cancel all elective surgeries for a 2-week period. And this was to free up hospital space and also the burden of the supply chain for PPE, personal protective equipment. That was followed up by recommendations from the Centers for Medicare and Medicaid Services, the Centers for Disease Control and Prevention, and the U.S. Surgeon General. And really, most of our dental practices shut down routine care from mid-March until mid-May. And in fact, as this graph shows, and this is the next 3 slides really are courtesy of the American Dental Association's Health Policy Institute, and all of these are as of November the 2nd of this year. But we've seen that practices have rebounded. The more of them have reopened to provide routine care, but they're all at level, or the majority are at levels lower than they were pre-COVID. And in fact, what we see is 38% of practices are reporting patient volume at levels at or above where they were pre-COVID, which means 62% of practices are not. And some of that is due to implementation of new infection control protocols. Some of it may be due to patients not returning to practices, and some of it may be the burden of the supply chain issues that we've seen globally. This graph shows how many days of personal protective equipment dental practices in the U.S. have. And the green and dark green show practices that have more than a 2-week supply. And what you'll see is that, by and large, most dental practices in the U.S. do have more than a 2-week supply of PPE. But there are still some practices that have no mask, no gowns, or very limited, as indicated by the red and orange, less than a week's worth. And we know that as the pandemic has worsened, it is putting increased pressure on the supply chain worldwide, especially with gloves and disinfectants. The American Dental Association also has contracted with an outside organization to measure consumer confidence in returning to the dentist. And what you'll see, again, this is as of November the 2nd, 83% are ready and willing to see a dentist. So 23% of people surveyed had already returned to the dentist. 60% said that they were, quote, ready to return. There were an additional 5% who were assurance seekers. And this number has consistently gone down as we've done a better job to educate patients about the safety of dental practices and the infection control measures that have been implemented. There are still a large number of Americans, 12%, that want to wait until a vaccine is available to them and that they have some assurance that the vaccine is effective. And I should mention one of the concerns about the coronavirus vaccine is that there is we see this with the influenza vaccine, that there is vaccine hesitancy in certain groups, especially minorities in the U.S. And so I think all of us as oral health professionals should encourage our patients to make sure that they get the influenza vaccine and the coronavirus vaccine, and concentrate especially on conveying that message to minorities. Finally, what I want to do is talk a little bit about the forthcoming Surgeon General's report on oral health. This is our U.S. Surgeon General, and this is the charge that he gave for the report. And if you look down at the bottom, there's a YouTube link. You can also just go to YouTube and type in Surgeon General and oral health and listen to him talk about oral health. But this report, which is still under development and will come out in the near future, consists of these different sections. It will include the effect of oral health on the community well-being and the economy, and then oral health across the lifespan, looking at children, adolescents, adults, older adults. It'll look at oral health integration, workforce, and practice issues. And like I did in this presentation, it will mention the effect of addiction and mental health disorders on oral health. And finally, it will look at technologies and science that will transform oral health in the next 2 decades. The report will emphasize the importance of poor oral health as a public health issue, reinforce the importance of oral health throughout life and its importance to overall health. It will discuss some of the issues, contemporary issues that I mentioned today, like an aging population and so forth. It will outline a vision and really lay the groundwork for the next 2 decades. And it will be at a level to educate, encourage, and call upon all Americans to take action. So as I wrap up, I just want to mention two last things. And one is, as professionals, let's set a good example and make sure we communicate the messages, the 3 W's, for everyone, especially during the holidays, to wear a mask, wash their hands, and we say sing happy birthday twice or count 30 seconds. And that's whether it's soap and water or hand sanitizer. And watch your distance, 6 feet distance, social distancing. And finally, you know, as we talk about COVID-19, other health threats and how dentistry, the new normal, we're still trying to define, let's look at what some of the opportunities are ahead. Things like teledentistry, how we can use it not only to screen our patients, but also to provide for specialists to provide consultative services to general dentists and coaching, how we can better integrate oral health and overall health in terms of education and perhaps vaccinations like for HPV, influenza, et cetera, how we can better connect with primary health care providers and refer patients to healthcare providers. And then point of care testing. There are opportunities in the future for us to do more point of care testing for chronic disease. There will be options for expansion of alternative workforce models like some of the ones I mentioned, and some of those may be answers in rural America and other underserved areas. And finally, we should be looking at ways to, not just during COVID, but post-COVID, ways to incorporate minimally invasive dentistry techniques such as silver diamine, fluoride, interim therapeutic restorations, and so forth. So finally, I just want to thank the American Academy of Oral Surgery, Dr. Shaw, Dr. Robertson, and all of you for listening in. Here's my contact information. Feel free to email me at any time if you have questions. And it's been an honor talking to you today. And thank you for your commitment to improving the oral health of those that you serve. Thank you.
Good morning from New York City to all my dear colleagues and friends around the globe. It is really a great honor for me to participate in this event, which is, in my opinion, absolutely unparalleled to all the previous. And also, thank you very much, Dr. Kayan Ashar, for inviting me to this event. My job today is to talk also a little bit, not only about the beautiful side of implantology. I was choosing to also to talk about the dark side. Yes, we will talk about implant complications, especially complex, unexpected, rare, and even life-threatening complications. Already in the year 2010, Stephen Eckert wrote in his editorial, "I believe that the study of and elimination of complication is the most fertile field in implant dentistry at this point of time." And in the same year, the AO put in their legal standards, in particular, the ability of the practitioner to predict, recognize, and treat complications from the treatment is of paramount importance. So the intention of my lectures is to raise awareness of surgical complications and also to help you to avoid and manage complications. What is our situation right now? We have more and more people which are choosing dental implants, but also despite advanced technology, there is a rise in the number of individuals with post-implant complications. And procedures are no longer limited to specialists. More clinicians who don't have advanced trainings are involved in implants. So some of these surgical complications might be relatively minor, but some of them, they end not only in the loss of the implant, but they result in the permanent damage of adjacent anatomical structures or even can be life-threatening. So that brings us to the point we all want to have success with our implants. What is success? Success is the accomplishment of an aim or a purpose, and successful implants have been clearly defined in the literature. And what is failure? Well, failure is the lack of success. We want to shift our field from failure to success. So the questions I try to answer is implant success meanwhile nowadays only the lack of complications? And are complications the result of poor decisions? Well, first of all, what is a complication? A complication is a secondary disease or condition aggravating an already existing one. And my personal experience is no matter whether we are dealing with early complications or late complications or intraoperative complications, most of these cases ultimately end up with the surgeon. So I will give you an overview on really surgical complications, implant related to anatomical structure and even life-threatening complications. Complications already can arise when we select our implants. We may select them too long, or we may even select them too short. We may even select a diameter which is way too far, so we compromise the bone or even adjacent teeth like seen here in these pictures. Another big issue is really how we position these implants. And we can malposition these implants in all kind of dimensions: buccolingual, apical corneal, inter-implant, and even the angulation. And here are some examples. You see here, this implant turned out to be unrestorable due to malposition of the implant. And there is even more. You see here, and here, and here. And the problem is that sometimes even these implants are getting restored, leaving unfavorable restorations to our patients. And how does it happen? Well, they can happen as a so-called freehand immediate implant, like here. This person better have used a surgical guide. They can also happen when we use flapless surgery. Here you already can see that something is wrong, and the exposure really showed that implant was completely malplaced. Same here. But even with the use of advanced technologies like guided surgery, implants can be malplaced. And I can tell you that sometimes if you have to deal with these cases, here it takes a year, sometimes even more than a year, to restore these patients again, to take out the implants, to take care of the defects, place new implants, and restore these patients. So malposition also can result in violation of biological laws. When we place these implants too close together or too close to adjacent teeth, like seen here or here, these implants have been restored and ultimately resulted in an early failure of these implants. Also here, if you place these implants too close together, we should not be surprised that this implant restoration will ultimately fail and even leave an additional defect. Also here, this implant was placed way too close. The angulation of this axis was disrespected, ended up in the loss of the tooth. That might have been a problem, although a guide was used. That these conventional guides have one problem. They only account for the position of the clinical crown. They do not adjust to the distal angulation of this canine root. Yes, and here I have another case. Yeah, you see the amount of implants, the inter-implant distance was completely violated. So-called teeth in 1 week. Yeah, and when I saw that patient, yeah, that was pretty much my reaction. It's not only the malposition. One step further is that we even injuring adjacent anatomical structures, typically wise that nerve. I was told to wait a year as the feeling might come back. And I said, I don't think so. Yes, these implant-related nerve injuries have become really the leading cause of nerve injuries. And the percentage is even higher than in third molar injuries. And this publication pointed it out. We may look into up to 13% of short-term incidents of problems with that nerve, and even a 3% long-term incidence after 1 year. Injury of the nerve can already happen when you do your incision, your flap, if you are disrespecting anatomical structures like here the mental nerve. Or they can result in stretching injuries, soft tissue reflection, excessive reflection, retraction, and even suturing of the soft tissue can result in a nerve injury, especially when we use big bone grafts. By over-retraction of the tissue, we can compromise this nerve. Statistics has shown that the level of these nerve injuries is quite different in implant-related surgery compared to other types of dental surgery. Yeah? Most other dental alveolar procedures only result in a neuropraxy, in a transient neurosensory disturbance, while implant-related nerve injuries show in a high percentage permanent problems. Why is that like this? Yeah, the problem is we have rather permanent problems because the drill or the implant itself may cut or even severely damage our nerve and ultimately results in a partial or even a complete transection of that nerve as seen here. And even that drill trauma, although a denser drill was used, bone fragments ultimately resulted in a pressure necrosis. Also here, on the other hand, this drill trauma resulted in a complete transection of the nerve. So for us, I think it's really important to understand the drill itself. Measure twice, drill only once. Always understand the true implant drill dimension and try to address it. For example, by the use of surgical guide and drill stops in order to prevent over-prevention. We should also try to understand the bony crest. If the width of our alveolar crest is not wide enough, we all tend to adapt the crestal ridge. But then we really have to measure from the point where we expect to be the platform at. So, and like this, we have to adjust our implant length. So if we shave off 2 millimeters, we have to adjust our implant length. Another common problem is when we place immediate implants in the mandibular premolar area, because these teeth are always very close to that mental nerve, as seen here in this X-ray. And we have to be aware that the mental foramen is right inferior usually to the second premolar in almost 73% of the cases. And in almost a third of the cases, the mental foramen is even superior to the premolars apex, as we can see here in this problem. So I'm always a bit careful with the immediate implants in the mandibular premolar area. We also have to be aware that there are a lot of variations when it comes to the mental foramen. And statistics show that in over 50%, the position of the mental foramen, what we see Okay. Should I proceed? Okay, I apologize for this interruption. Obviously, there was a problem with the microphone. Yeah, what I wanted to mention, and I proceed where I stopped, that yes, we also have to consider that the mental foramen has a lot of variations. We know that in over 50%, the mental foramen is in a different location than depicted in a 2D image. We have to be aware of that. And there are even other variations, like an accessory double foramen. Yeah, we should always look for that, because in 8 to 10% of the patients, we can identify an accessory or even two accessory mental foramen, as you can see here in these pictures. So when we place implants, we need really good evaluation of the anatomy. And this publication show that. Yeah, for example, post-implant neural damage occurred 90%, and a CBCT was not available. Or here, 54% of the injuries resulted from inadequate radiographic assessment. That doesn't go that far that you always have to have a CBCT, but you have to have appropriate imaging and a good pre-procedural assessment of the mental and the inferior alveolar nerve. And yes, and it can happen. When you only take a pan, you may not be even able to localize that nerve. The corticalization can be so significantly decreased that we cannot even identify our nerve. So it's really important to take a CBCT at that point and clearly identify this mandibular canal. And this mandibular canal is always clearly visible if you have a good cortical component like here. But ladies and gentlemen, be aware that this is not really a cortical bone. It's a kind of a coalescence of trabecular bone. Yeah? And studies have shown that even with a CBCT, the inferior alveolar nerve is only clearly visible in about 53%. In about a quarter of the cases, it's even difficult or even very difficult to visualize this nerve. And also be aware of that if you're only using a panoramic radiograph, these radiographs have a kind of uniform magnification. It might be okay, and we are able to determine the vertical magnification depending on the localization, but the horizontal magnification is entirely inaccurate and cannot be used. So what is happening? We place an implant, and in our post-op assessment, the implant is in or at the mandibular canal, and we even face an altered sensation. It's not necessarily that there is an altered sensation, but if there is an altered sensation, we have to think about it. We, at least at that point, should take a CBCT and then decide what is best to do, to reposition, to replace, or even to remove that implant. Because what can happen? Yeah, it's like in this case, for example, yes, that canal can be violated, but most likely it's not really transected. So an early removal of this implant can lead and will lead to a partial and even complete resolution. If you wait too long, this may even lead to a further injury or even in neuropathy. Well, here in this case, this canal is clearly transected as shown in the CBCT. So it's very important if we are dealing with this kind of injury to clearly differentiate between, on one hand, a situation where the canal might be violated but is not transected. In these cases, we back it out, or we may even remove the implant, and we give anti-inflammatory drugs, topical or systemic. But in cases when the canal has been trisected, then a surgical procedure has to happen. But on the other hand, just to remove this implant doesn't serve any purpose. We should really leave that up to the surgeon. He may even keep the implant and only fix the nerve. And surgical approaches to these nerve injuries, they can be such like a decompression. Sometimes we have to remove a neuroma, which is caused by this irritation, and sometimes we even have to reconstruct that nerve with an autogenous nerve graft. Or the latest approach, we have even autografts and allografts like Avance to bridge a transected nerve. Sometimes, like in this patient who presented, he had a transection of the nerve. The implants also integrated perfectly. To remove these implants wouldn't have served any purpose, so these implants have been even restored. And please be aware, meanwhile, we are in a situation where about 24% of all malpractice claims are related to nerve injuries, and some law firms are even actively advertising for this kind of issues, and you may end up in a lawsuit. And here I give you an example. This was filed in Florida, and the verdict was about $633,000 US. So, yes, an ounce of prevention is worth a pound of cure. So, in order to prevent that, really have a thorough diagnosis, measure and plan carefully, use CT-based guides, always maintain a 2 millimeter safety distance, do intraoperative radiographs, use drill stops, and immediately after the implant placement, take a radiograph to confirm the proper position of your implant. Other injuries to adjacent structures may result in perforation, migration, or even displacement of the implant. Let's look at the maxilla. Yeah, implants can be displaced here in the maxillary sinus. And I have 20 or 30 more of these x-rays. So this is, it's not very common, but I wouldn't say that this is completely uncommon. Also here, this people, they didn't give up. They even placed more implants, and out of a sudden 3 implants were ultimately, they ended up in the maxillary sinus. But even post-operative, we observe the migration of implants. This can be due to the fact that there are changes in the intrasinus cavity. It can be an infection, peri-implantitis, or just lack of primary stability when we do these crestal sinus lifts. And once they are in the sinus, these implants may even have a tendency, or they love to migrate, like here, all the way up to the ostium area. And once they are in the osteo area, they may even try to migrate through the osteometal complex, and they can end up, as seen here, in the ethmoid sinuses. They can even migrate, like here in this case, into the sphenoid sinus. Also here, they may stay in the sinus, but then they migrate into the orbital cavity. Or so you see here, this implant is definitely outside the sinus, migrated into the orbita. You see this here. Also, this case recently published, this implant was intracondylar orbital displacement posterior to the ocular globe. Fortunately, no visual loss was observed, and the implant could be removed. And yes, there is even one case published in the literature where the implant migrated into the anterior cranial fossa and had to be removed. Yes, that's how it feels like when you know that you shouldn't have placed this implant. As all maxillofacial surgeons, we have different ways how to recover these implants. The endoscopic approach is mostly reserved for the ENT doctors, while we as oral surgeons probably prefer the Calvo-Luck approach, like seen here in these pictures. We are all trained in these procedures, and that would be a way to recover them. Not only the sinus, it can be also the nasal cavity, which can be perforated. And we see here in this case that this implant is definitely perforating the nasal floor or here. Of course, these implants should be removed. They could alter the nasal airflow and increase mucus secretion and even give us a scar formation. Especially the use of zygomatic implants, as seen here in this case. If done by an untrained person, can cause severe injuries, like here a transection of the lateral rectus. The implant is here clearly in the orbital cavity, or here this implant here clearly perforates into the orbiter. And here another case, this zygomatic implant was performed under general anesthesia, and the tip of that implant ended up being in the brain. So, and that patient waited about 1 year and presented with severe headaches actually from day one of surgery. What can happen in the maxilla also can happen in the mandible, especially due to the anatomy of the mandible. Yeah, in these highly atrophic mandibles, we often see these hourglass-shaped undercuts, and they can be a problem, especially if you are performing flapless surgery. You see here, if you are not really familiar with the anatomy, then you may perforate your lingual plate, or here, and this can have even, it might not only be a perforation. This implant, for example, was completely dislodged into the submental space, as we can see here in these CT scans. Was not even palpable intraorally, so ultimately even had to be removed from an extraoral access. You see here, and all this because of the lack of primary stability due to perforation. But it's not only an anterior lingual concavity, it's also especially on the posterior mandibular side. Under ideal condition, yeah, we have this shape of a mandible, and that would be perfect to place an implant. But in many situations, we are looking in a very concave-shaped mandible. And this here is a mylohyoid ridge. There is an artery literally waiting for you. And that's the problem with this local anatomy. And you see here, perforations of the lingual plate may happen here quite often, as you can see in this collection of this X-ray. So it may look perfectly on the crest, but if you drill too deep, you end up in the floor of the mouth. And well, best case scenario, or what you get a hematoma, because the implant perforates here and hits an artery. This still had a more or less favorable outcome. But here, in this case, the implant was perforating the lingual plate, got dislodged into the submandibular space, and fortunately, I was able to help this dentist out, so we could literally push that implant back through an intraoral access and ultimately recover that implant from the submandibular space. In this patient, it was not as lucky. There was the dentist tried to remove this implant due to lack of stability, and while removing the fixture got dislocated and was no longer palpable from the intraoral side. So it had to be removed extraorally, and here we even see that there was a huge fenestration in the lingual cortical plate as a result of perforation. As I said here, if you perforate, you may also end up not only in the dislodgement of the implant, you may even cause a hematoma. And this hematoma can be really very, 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 very big and may even compress our airway. Also here, this 76-year-old woman had actually 2 implants placed. Very simple interforaminal implant. But this implant, you see here, perforated the lingual plate. This patient ended up, was admitted with a protruded tongue in the oral cavity, needed emergency tracheostomy, and was in intensive care for 4 days. Also, as you see here, these hematomas, also here, very simple implant placement, number 26. Patient literally presented with a kind of pseudo-Ludwig phenomenon, massive hematoma in the floor of the mouth, causing a huge swelling, protrusion of and displacement of the tongue, and ultimately obstructing the airway. This patient needed a trach. And why is all this? What is the problem? Yeah, it's that sublingual artery. here, and especially all the variations. And this is a very variable artery. It has ascending branches in almost 94% of the cases. And what many providers don't know, there are a lot of accessory lingual foramina on the lingual aspect of our mandible. They might be small and they may have not a name, but they have a sufficient size to house an artery and cause a severe hemorrhage during implant placement, especially when we are using very long implants. These foramina are there in almost 100% of the cases. There might be a medial foramen, and there also might be lateral foramina. And that's how it looks like. You drill and you literally see a significant bleeding out of your osteotomy. So it's very, very important for us to understand the local anatomy, that the arteries we are dealing with, and we have these three arteries which ultimately supply the floor of the mouth with blood. Yeah, and if we have that bleeding, the general recommendation is it's most likely the submental artery as a branch of the facial artery, which should be ligated first. But in very, very few cases, it might be even the lingual artery. And that's how you run into trouble. These are your pathways to trouble. You're causing a surgical trauma that ultimately ends up in a vascular trauma, which gives you a hemorrhage. This displaces the tongue and the floor of the mouth, and ultimately ends up in an upper airway obstruction. So if this ever happens to you, the first attempt is always try to stop the bleeding with a tamponade, with hemostatic agent. Try whatever is possible, and of course refer that patient to the emergency room. Once in the emergency room, well, we may only monitor these patients, but in a majority of cases, these patients have to be intubated and the hemorrhage had to be stopped by evacuation of the hematoma and even a ligation of the artery. So no matter what happened, that's of primary importance. If that bleeding happens, our primary goal is to isolate and to stop the bleeding, but also especially to maintain our airway. This not only happens in the mandible, it also can happen in the maxillary hemorrhage. We all know this anastomosis between the infraorbital and the superior posterior artery. And these arteries, these anastomosis, as you can see here, can have a really big diameter. So we have to know, where do we find it? In most of the cases, it's an intraosseous anastomosis, but it also can be on the outer, but also in the inner side of the facial wall of our facial wall of the sinus. And you see here, really huge diameters, so we can isolate this artery. But if it happens also here, we try to apply pressure. We can cauterize it. In some instances, it's even necessary to prep a second window distal to the bleeding area in order to ligate these bleedings. In some instances, if we can identify that blood vessel, it can be a very good idea to use a piezo to isolate that artery and to ligate it, and then proceed with our sinus lift in case you know what you're doing. Another severe complication is a mandibular fracture while implant placement. This can happen in certain instances, like an atrophic mandible, like an infected implant site, Ramos graft. I will give you some examples, especially in implant placements in a highly atrophic mandible. A mandibular fracture can happen if you are perforating the inferior borders. So my advice is really, when we have that situation, try really to preserve an intact buccal, lingual plate, and inferior cortex. This will give a lot of stability to the lingual, and in many cases prevent a fracture. But also when an implant is getting infected, it may cause a localized osteomyelitis, which ultimately leads, like in this case, to a pathological fracture of the mandible. Also here, a transposition of the inferior nerve was performed. 4 weeks later, the mandible fracture. If we do this, I personally would always recommend that these implants, they may engage, but they should never disrupt or perforate the inferior border of the mandible. That's definitely a pathway to a fracture. Or if we are taking an oversized Ramos graft, really consider the dimension of the mandible when you are planning your Ramos graft. Otherwise, this happens like here about 1 week. Even here, I was a legal case I was involved in. was the expert witness. So even the osteosynthesis was performed really very poorly. Yeah. Mandibular fractures also can happen when we perform alveolar distraction osteogenesis, especially late fractures. So we really have to be aware that 50% of this type of fractures are happening when the bone height is less than 2 millimeters. So that makes this kind of condition a severe atrophic mandible a kind of a contraindication for this procedure. But also an ongoing peri-implantitis under certain conditions can be a problem for the stability of our mandible, like in this patient. Well, this patient even had radiation therapy, developed a peri-implantitis. This went into a osteoradionecrosis, and so the mandible fractured and had to be fixed. So far, they were kind of localized complications, but sometimes a complication may even turn into medical and even life-threatening complications, like here in this scenario, maxillary hemorrhage, severe hematoma formation secondary to a zygomatic implant placement. So most likely it was never clearly identified. It was due to a laceration of the PSA or the paragoid plexus in the midface. Also here, actually a simple implant placement in the maxillary anterior regions caused an arterial bleeding. The tongue got, you see, elevated up to the hard palate. In the office, a relieving incision was performed. Then, of course, in the emergency room, a fiber optic intubation had to be done. The patient was no longer was in a condition, so an oral intubation was impossible, and even that fiber optic intubation was very difficult, and he needed even a temporary tracheostomy for 3 days. And here you see this fiber optic assisted intubation that really needs also advanced skill set from the anesthesiology and emergency medicine doctor. Then another thing, aspiration. Really always secure instrument. This patient presented only with a irritated throat, and fortunately this screwdriver, which ended up in the piriform fossa, could be recovered by direct laryngoscopy and the manual forceps. But sometimes also these pieces, whether here a abutment or a screwdriver, they travel all the way down, and the patient may even aspirate this, also seeing here. And this, of course, if this ever happens, this had to be removed by bronchoscopy. Implants or implant parts like this implant drill or like this screwdrivers, they are not getting aspirated, they are getting swallowed and indigested. So it's very important, if any instrument or any implant part disappears in the throat, we have to localize this instrument and then do the right thing. It might be a bronchoscopy, it might be only a follow-up. You see here this implant part. Fortunately, in many cases, this foreign body leaves the body and expelled naturally, like here, within 5 days, but this has to be conformed. Also here, day one, we see here, this implant part was in the stomach, but after 6 days, this implant part left the body. This patient was not as lucky. You see, even after 7 or after 14 days, this screwdriver didn't move at all and had to be recovered by colonoscopy. So please always, when you're dealing with these tiny implant parts and screwdrivers, use a throat pack. Make sure nothing drops in the mouth and in the throat, because then these things may happen. Infections may also may also bring our patients at risk. And I think we all have seen that this kind of infection, as long as they are localized, we will be able to deal with this. And the postoperative infections, well, they have like an incidence of 1.6 to even 11%. And the problem is with these early implant infections, they don't really respond very well to antibiotics and frequently persist until that implant is really removed. And we know from the literature that these single dose antibiotics don't really have any effect on the prevention of postoperative infections. Once these infections happen, they are actually a big risk factor for osseointegration and are a main risk factor of early implant failure. So yes, we may start by prescribing an antibiotics, and the most suitable you can see here, but experience and the literature shows that the vast majorities of patients, the infection will not get resolved. They need additional surgical intervention because of a systemic antibiotic failure. So this more or less brings the local application of antibiotics into the foreground. Yeah, it's, well, kind of pest control in gum gardening. I took that quote from that article, but we have to understand that an early infection of an implant most of the time requires surgical intervention. But then there are also other scenarios. The implant site. It's not only the implant, the entire implant site got infected and causes a localized osteomyelitis, as seen here. So already the entire bone is infected. Of course, this implant has to be removed. The bone has to be debrided, and the patient needs antibiotics. But here in this case, you see, the implant got infected. The surgeons removed it, but then even after like 1 month, we already see that something is going on in the bone, and after 3 months, we see there is a significant bone condition. Yeah, it was ultimately a chronic osteomyelitis. So this patient ultimately ended up in a resection of almost 50% of the mandible, caused by an implant infection. Also here, this patient, 61-year-old woman, with recurrent perimandibular abscesses, even with surgical drainage, and high-dose intravenous antibiotics. But as we see here, after 2 months, the entire bone destruction doesn't look good. And after 6 months, you see that moth-eaten, stippled appearance of the bone. Even we're seeing very well here in this scintillation scan. And what happened, this patient ultimately had a refractory osteomyelitis, which also ended up in a hemimandibulectomy with partial mandibular reconstruction with a free fibular flap. Surgical site infections may not only stay in the mandible or around the mandible, they even can spread. Like this 54-year-old, diabetes, had 4 implants placed, had antibiotics, everything was fine, but then presented to the emergency room with fever and the right submandibular swelling. A CT scan revealed a huge formation of pus, all these hypotense areas you see here. So yeah, this patient ended up with a deep facial abscess, and this abscess, you see here, all these hypodense areas, that's all pus, almost went all the way down to the mediastinum. Of course, this patient required an incision and drainage. Also here has a small cortical perforation, but we already can see here a gaseous collection in the floor of the mouth, showing that something is going on. Yeah, perforation, and this patient worsened on day 5 with a facial, laryngeal, and tongue swelling, and ultimately this has been diagnosed as a descending mediastinitis. So how does that happen? Yes, there are multiple pathways from a dental abscess or a peri-implant abscess all the way into the mediastinum. Yeah, certainly gravity and the negative intrathoracic pressures facilitate this spread of these infections, but we should really be aware of. Yeah, and when patients come back and they present with these kind of symptoms, fever, dysphagia, redneck, this redness all the way, we must get really alert, and we may order a CT scan to diagnose what's going on, because we don't want that these patients end up like that with multiple surgical drainages, systematic antibiotics, and even supportive medical care in order to save their life. Well, all things can go south, but they also can go north. Like here in this patient who had an extraction of a number 8 in a socket graft, 40-year-old, presenting at the emergency room with a swelling of the right side, dilated pupils, diplopia, and an abducens nerve palsy. So what happened here? Yeah, this patient ended up having a cavernous sinus thrombosis, a life-threatening condition. How does that happen? Yeah, we have to know that any kind of infection in this triangle of dangers can ascend into the cavernous sinus through an anterior route or even through a posterior route via the transverse facial vein. Yeah, we have to know coronal sinus is really life-threatening, and due to this highly vascularization that easily spreads to the contralateral side. So if a patient really presents with these symptoms like headache, ptosis, dilated pupils, but especially all kinds of ophthalmoparesis, whether it's the cranial nerve number 4, number 6, but especially number 6, the abducens nerve, we should be very alert, and that's technically a pathognomonic sign. If you see this patient belongs to the emergency room right away. And here in this publication, even a brain abscess resulted from an implant placement and a crestal sinus lift. And as we learn, yes, there is this triangle of danger, which ultimately resulted in an abscess formation in the brain. So what can we learn from all these situations? Yes, good surgical techniques involves really the use of a true aseptic technique consisting of sterile drapes and gowning. And yes, and clean surgery can technically really and will decrease the possibility of contamination of implants from pathogens and hopefully prevent all kinds of infections. And surgical complications, they can be minimized. So please always have a good indications, not like here. Have a good treatment plan, unlike these two cases. Have a clean surgical technique and always perform a meticulous hygiene. Select a modern implant system. These are definitely outdated, and have an appropriate design of your prosthetic superstructures. I'm not an enemy of implants. Actually, I love implants, and I know that implant placement is a controlled surgical procedure, but, and that's a big but, even a simple implant procedures are invasive in nature and can trigger extremely serious and even life-threatening complications, as we learn during this lecture. And oral surgeons, oral maxillofacial surgeons, and dentists, no matter how skilled and no matter how experienced in implant surgery they must be at all times be aware of this kind of complications in order to promptly plan and interact and intervene in these emergency situations. And yes, the lack of complication and appropriate techniques are key factors for implant success. So, in order to answer my questions, are complications really the result of poor decisions? Well, the problem with decisions is, and I agree fully with Dr. Einstein, good decisions come from experience, and experience come from bad decisions. So I always wish you good decisions in your daily practice, and decisions which derive from your experience. And I want to thank you very much for your attention, and I wish you a good time and enjoy the Global Summit of the American Academy of Oral Surgery. Thank you again for invitation. Thank you again for attending these lectures. And if you want, I'll be back in one of our future meetings. Thank you again very, very much.
Good morning, everyone. We have Samir Basin from CareCredit. It's a pleasure to have you, Samir.
It's a pleasure to be here. Good morning and happy Saturday.
Yes, happy Saturday. Yeah, it's great to be here. It's a very exciting day. This is our symposium from American Association of Oral Surgery. And, we're so excited to have you here. So Samir is going to be representing CareCredit here. And so excited to have you here. Samir, I personally have some questions. I know you guys have had, there's always new technologies and we all use dental softwares, one or the other, but and I know that you guys just recently, I saw that the one I use is Open Dental, and I know you guys just making it easier and easier. Is that the only software you guys are integrated with, or?
Oh gosh, no, you're absolutely right. So it's one thing that and I've been with CareCredit almost 14 years. One thing we pride ourselves in is how can we make it easier? How can we make it easier for our dentists, for their teams, and definitely the reason we're all in business, for our patients. So we, long time ago, we decided, since the majority of the team lives and breathes in practice management software, how easy would it be if we were integrated? So they don't have to go, again, kind of going back to making it easier for them to use. So they don't have to go outside of practice management software, go to the website, apply for make applications or do transactions, etc. So Open Dental is definitely one of our newest ones, and we're very, very excited about it. We just, I think it went live 2 weeks ago. And so there's actually one very cool feature, and I'll talk to you in about a second about it, that is available for Open Dental users. But other than Open Dental, we are integrated with Dentrix as well, Eaglesoft, and CareStream products too. So yeah, and the change that we had for or a newer feature that we had that we in fact we launched it with Open Dental is called Batch Quick Screen. So what is Batch Quick Screen? So and like I said, I've been with the company 14 years, and one challenge that I always heard, even when I was a rep or managed a team, from our dental teams was, I don't offer patient financing because I don't like, I don't want to have that difficult conversation of saying, I'm sorry, you were not approved, or you were declined, or so any of those in that arena. So we said, okay, it's a fair question because not everybody's comfortable discussing money and having conversations about money, especially when you start looking into $5, $10, $15, $20, $25, $30, $50,000 range. So Quick Screen does, it's more of a training wheel. I use that as, I would say that as a training wheel. So would it help you or your team if you knew ahead of time, before time, all the patients that are either coming today or this week, which ones already have a CareCredit card, which ones will get approved for a CareCredit credit card if they were to apply, and third, of course, which one should definitely do a full application. So the easiest way for me to say what Quick Screen is, or it used to be called pre-approval, I'm sure you receive invitations or you receive offers from Visa or MasterCard saying, hey, Dr. David, you've been approved for whatever. So it's more of a pre. So we did the same thing for our patients, for our teams. So now it automatically, it's part of the software. It automatically does a Quick Screen. So if you have 20 patients coming today, we may come back and say, hey, there are 4 patients who already have a credit card through CareCredit. There is 3 patients who will get approved or who can get approved, even though they don't have it. So it kind of boosts that confidence because if it comes back as pre-approved or Quick Screen, then there's a very, very, very high chance we will approve them for a credit card. So that's one of the coolest ones. Other than that, the applications and doing transactions. So
that sounds great. Yeah, that sounds great. So it's kind of you get a preview of basically what your day is going to be like, and what patients are able to get the credit and who not. So that's very important in my opinion.
Yeah, because I mean, the last thing you want to do as a practice owner is to carry or try and figure out who is a good credit risk or not. Leave it to the banks. That's what we do. That's what we have, the systems and the processes in place to make sure that you have that. So this way, it makes for a great morning huddle conversation. Now you know which patients will be approved. Now you know how can we better communicate and educate and create that sense of urgency that the patient will say, let's do what you're recommending versus what does my insurance cover? Let's only do that. Because it all kind of comes back to money a lot of the times after value if they don't see one.
Right. And so it definitely helps a lot to know who can get pre-approved or not, or like you said, people who already have the care credit. So, yeah. but it's easy enough right there on the software to just look at it as the quick screen, you call it.
Absolutely, yes. It's called Batch Quick Screen. It's you just have to, I believe you have to opt in, and for open dental users, and you can just say, and it will every morning it will give you a report of on your schedule. It will actually have like one of three icons, either like a triangle or circular and green in different colors. That will be indication of who already has it, who would need to do a complete application, or who has been pre-screened and has quick approval. So it's all HIPAA regulation. It's all it's compliant with HIPAA. We're very, very particular about it. So and the good part is you don't have to have patient's permission because you're not using their social security number. It's similar to just like insurance companies and mortgage companies and those credit card offers, how you get it. It's the same thing. It's using mostly public information. So
right. So and Sami, one of my office manager actually told me something that the patient needs to now apply not from the office anymore, right? Something like that.
So you must be in California then.
Oh yes, in California.
Yeah. So California in July activated. It's called SB 639. It's a Senate Bill 639, which basically says that your team member cannot apply for the patient. So the patient has to do the application on their own. So Quick Screen is not doing an application. It's just an offer to do an application. It's just for you to know what is the credit risk of that patient. So as a result of which, I'm so glad you asked, as a result of which, irrespective of whether you're in California or anywhere else in the US, we've developed what we call contactless technology. So the QR codes. So you can have a QR code that is customized for your practice. So the patient, all they have to do is just take this phone, take the QR code, and it pops the application on their screen. They do the application right there, and if they are approved, they would know that immediately. So
that's right.
Yeah, so again, making it easy for your teams. One last thing, and the team is not responsible for keeping the paperwork for 7 years or anything like that. So it's all in patient's hands.
Got it. So also I tell you, so right when the COVID hit, and I heard that almost everybody cut down the credit limit for all the patients, and so I know you guys have been very active. I mean, I read things here and there, but I know you guys have also been very helpful and trying to help the community and help the practices, and
it's and you're right. I mean, yes, it's a different time and a different day, but we've been doing this for 33 years. I mean, this is not the first time we've seen an ebb and flow in how the economy is and how the employment market is or anything like that. So we've had a formula that's worked for years and years and years. So fortunately for us, we've not seen a whole lot of change. Ultimately, it all comes down to how can we better educate our dentists and our teams, and that's what my reps do. It's even though they're doing everything virtually, but that's what they will do, is to be a resource on not only how to do more care credit, but how do you have a conversation, the verbal skills with the patient, or the resources and tools are available so that it makes it easier for them. So again, this is our focus. We've been doing it for, like I said, 30-something years. Yes, it kind of is more of a speed bump than a wall. So we are over it, and we're working towards it. And with the help of our doctors and their teams, it's ultimately, like I said, what you do, what I get to do is for that one patient, for that patient.
So you would say we're pretty much back to where we were pretty much now, as far as lending.
It's actually, I mean, it will get back all the way once we get our doctors to see because the patient volume is not back all the way. So right. It is heading in the right direction.
Absolutely. Yeah, we see about maybe 25% less, and this just and then you also see the believe it or not, so we're seeing it to come back fully actually right now, right? So people are coming back and they're not having any problems. Anything else you want to share with our audience today about CareCredit?
I'm sure they have multiple questions. I'm sure they have questions about the fees. I'm sure they're wondering as to how is the approval rate in their own area for their practice. As much as I would like to give everybody information right now, generic information, I think I would be doing them disservice. So the best thing would be, I want you to connect with your rep. In order to make that happen, I'm not sure if we would have the opportunity, but feel free to give out my email address, which is sbhasin, which is my first initial last name, SBHASIN @carecredit.com. Feel free to send me an email, and I'd be more than happy to connect you with your rep and hopefully help you and your team and your patients do what we love this profession for, and making everybody healthier.
Perfect. Thank you so much, Samir. It was really nice to meet you in person.
You too.
And hope you have a wonderful Saturday and, for a better year.
Yes. Thank you. You do too. And have a great summit.
Thank you.
Thank you. Bye.
Hello, my dear friends. A very good evening from the wonderful Germany here. I'm very honored to be here as a keynote speaker for the American Association of Oral Surgery Global Summit 2020. My name is Dr. Sangeeta Pai. I'm working as an oral surgeon implantologist in Germany. Starting with the topic today, it's a very interesting one called as demystifying bone augmentation in implant dentistry. I would put it up as a stepping stone topic before one starts hustling into the journey of implantology. So as the word suggests, it is about how we can create the bone which is missing when we want to place the implants. So today's presentation I have divided into a few subtopics so that it is easier for us to navigate. We'll talk about the introduction, then the bone augmentation material, the source of action, and the source, based on the source, the type of augmentation materials, the barrier membranes, the fixation elements, the keys which are needed for successful bone grafting, the complications which could occur, which is very common in most of the cases, or most of the things which we do. And the last one is the clinical cases. We'll be seeing few interesting clinical cases. So let's start with the introduction. So bone augmentation or bone is required when we have ridge defects, and ridge defects develop as a result of the surgery, trauma, infection, or congenital malformations. The goal of bone augmentation is maintenance of the contour, elimination of the dead space, and reduction of the postoperative infection, therefore to enhance the bony and the soft tissue healing. The insufficient quality of the bone is due to the tooth loss, which results in rapid resorption of the alveolar bone due to the lack of intraosseous stimulation by the PDL fibers, like in the pneumatization of the maxillary sinus after the tooth loss, which is usually seen when we extract 1/6 or the upper primary maxillary molar, and after 3 months when you take an X-ray, there is a complete pneumatization of the maxillary bone. The bone grafting is a surgical procedure that replaces the missing bone with material either from the patient's own body, the artificial, synthetic, or the natural substitute. Bone grafting is possible because bone tissue has the ability to regenerate itself completely if provided the nutrition, space into which it has to grow. Bone augmentation material on mode of actions. It is divided basically into 3. The osteoconductive, the osteoinductive, and the osteogenesis. Osteoconduction, as the name suggests, occurs when the bone graft material serves as a scaffold for the new bone growth. The osteoblasts from the margin of the defect that is being grafted utilize the bone graft material as a framework to spread and generate the new bone. The most common osteoconductive bone materials used are alloplasts and xenografts. Coming to the next is osteoinduction. Osteoinduction involves stimulation of the osteoprogenitor cells to differentiate into osteoblasts and therefore help in formation of new bone. The most usually used osteoinductive cell mediators are the BMPs. A bone graft material that is osteoconductive and osteoinductive will not only serve as a scaffold for the currently existing osteoblasts, but also trigger formation of the new osteoblasts, forming integration of the graft. The most commonly used are the autografts and demineralized bone matrix. The third, depending on the mode of action, is osteogenesis. Osteogenesis is nothing but production of the bone from the osteoprogenitor cells, which differentiate into osteoblasts and therefore form a new bone. It occurs in cases where we use autografts and allograft materials. The second formation of the bone augmentation material based on the source is autografts, allografts, synthetic, and xenograft materials. Talking about the autografts. The autografts, as the name suggests, involves utilizing bone obtained from the same individual receiving the graft. The bone can be harvested from the non-essential bones in the facial region, like the symphysis, that is the chin area, anterior mandibular ramus, or the iliac crest. When a bone graft will be performed, autogenous bone is the most preferred because it has a less risk of graft rejections, as the graft is originated from the patient's own body, because the patient itself is the donor. It would be osteoinductive and osteogenic, as well as osteoconductive. So it has all the three properties. The disadvantage, although, is that an additional site is required, additional surgical site is required. Very important is the surgical precision. You need to be a well-versed surgeon to provide or to operate such kind of autograft procedures. The resorption rate, unfortunately, there are not many studies which show us the resorption rate other than the Widmark et al. Study in 1997 and the Cordado et al. Study in 2010, which suggests around 25 to 30% of bone loss. So there are cases where I personally use autograft with xenografts, and I have very good results. So you have both the good qualities of both the things. So as the picture here suggests or shows, you have a piece of the ramus mandible which has been removed. It has been fixated with the help of the screws, and the space between the rest bone and the plates is filled with bone chips, and these bone chips, one can use something called as bone scrapers, which is easily available, and you can just scrape the bone from the mandibular region, or you can thin the plates which you have harvested, and we suture it back nicely and closely. Coming to the next one is the allografts. Allografts is derived from humans. The difference is that the allograft is harvested from an individual other than one receiving the graft. There are three types of bone allografts available. You have the fresh bone, FDBA, and DFDBA. The use of allografts for bone repair often requires sterilization, deactivation of the proteins normally found in the healthy bone. But it is nowadays a very normal surgical component which we use. At least here in Germany, you have a company called as Botus Straumann, where you get preformed bone plates, and they are square, and I usually tend to round the edges off so that there is no dehiscence of the soft tissue. So you place, as you do an autograft, it is placed or stabilized with pins and covered with a membrane, which is a resorbable membrane, and which is a suture back. The advantage of this is you don't need extra surgical site. The patient doesn't have to have two operated sites at the same time, and the surgical precision, of course, is required, but it is easier as compared to harvesting your own autograft. Synthetic variations. Artificial bone can be created from ceramics such as calcium phosphates, flexible hydrogen apatite crystals, which has a mineral to organic matrix ratio approximating that of the human bone. So the regeneration is really very good in such case of synthetic variations. They are biologically active depending on the solubility in the physiological environment. These materials combine with the growth factors and can result in higher bone mineral density and enhanced osteoblast proliferation. Coming to the xenografts, I usually in my practice, more than 70% of my cases are with xenografts. I tend to mix xenografts with autografts when I'm doing larger procedures. Or I have even done cases where we have used the plates, which I told you, the allograft plates for the xenografts. It works fine too. It's very important to decide which kind of bone material is appropriate for which kind of cases. We'll coming back to the topic once we see a few cases. So coming back to xenografts. Xenografts, as the picture depicts, are bone grafts from species that are other than humans, such as bovine and porcine. They're used as calcified matrix. These are basically osteoconductive and help in scaffold bone formation and are available in different range of volume and particle sizes. The grafts are cleaned, sterilized, and prepared for implantation into the human body. Coming to the barrier membranes. Barrier membranes, if I may put it, is something called as control forces. It helps in keeping the bone where it belongs and allows the soft tissue to grow around it. So it is very, very important that we get a little bit of information about barrier membranes. There are basically two types of membranes. One is the resorbable and the other one is a non-resorbable membranes. The resorbable membranes, the most important advantage of the resorbable membranes is elimination of the membrane removal after healing, resulting in decreased morbidity, easy manipulation, and lower rate of complications. These membranes can be used with bone graft substitutes and additional tools such as tenting screws or plates for the space maintenance. Resorbable membranes that are made of native collagen show high biocompatibility, resulting in good tissue regeneration and a rapid vascularization. The second one is the non-resorbable membranes. When a high amount of bone augmentation is required, reinforced non-resorbable membranes are used. Reinforced membranes withstand the pressure from the surrounding tissue, resulting in the prevention of membrane collapse and allowing the bone to regenerate during healing. Titanium mesh, titanium reinforced expanded polytetrafluoroethylene, that is the PTFE membranes, are most commonly used. I personally tend to use non-resorbable membranes when I'm doing upper and lower full mouth rehabilitation cases where we have a completely resorbed maxilla and mandible, and we try to build it up. And there are patients, even though the autografts or allografts are much more meaningful because they give a lot of stability or act as a wall, the patients tend to sometimes deny that option. So in that case, non-resorbable membranes work wonderfully because it is always a multiple stage surgery. So first we build the bone, and then after 4 to 5 months of the primary healing, we place the implant. So there is no extra surgical procedure which is required to remove the membranes. You can always combine it with placing the implant. So when a very large amount of bone regeneration is expected, then non-resorbable membranes are one of the best options. So, keys for successful bone grafting. Yes, this is very, very important to keep in mind that every patient is different. So I usually take time. The first appointment with me is very important because I take time to understand what is the patient's wishes, what is he expecting, he or she expecting after this treatment, So a holistic approach, holistic surgical approach is very important. I call it holistic because you have to give the patients the part too, that it has to heal well. So, it is very important to make it understand that it is a two-way road. We can do the best as surgeons, and the patients have to equally take care of themselves. So the patient-related factors, then we have the technical factors, the type of material which we used and how much time do you allow it for healing, etc. The biological factors. Then we have the post-operative care. Coming to the patient-related factors, the patient communication, as I told you, is very, very important. Talking to the patient, telling the patients that you are aware of their wishes, you are aware that what surgery is awaiting, and you clear them about all the risks, the amount, the time, the money, because all those things are very, very important. When we are talking about full mouth rehabs, I think the most surgeons are well aware that it is, we are talking about a very big amount. So the patient have to be cleared about everything, not only the physical stress, but also the financial that comes with it. So a customized growth plan is very, very important when we talk about patients. The second one is the general health. So it is very important if the patient is healthy, if he has diabetes, if he's on blood thinners, because then you have to always see to it that 24 hours the blood thinners are not taken, or has to be subsided or taken care of with heparin. So all those things are very important. If the patient has osteoporosis, if he had malignancies. Oral hygiene is also very important when we are doing full mouth rehabs, or when we are doing multiple implants. We tell the patients to undergo periodontal treatment and mouth cleaning, full mouth cleaning, before we start with the procedures. Smoking and periodontal health play a very important role in the healing of the implants. Patience and trust, yes, of course. It is an invasive procedure. Even placing implants procedure, or if the bone, anything related to surgery is an invasive procedure. So it's very important to give the patient the confidence that he's in good hands, he or she is in good hands. The third one is good planning gives a predictable outcome. The technical factors: analysis of the case, begin with the end in mind. You have to plan from A to Z. You cannot say, let me see how things go on. No, you have to have a plan A, B, C, and you have to start with the planning from A to Z, so that before you start even placing the first incision in the patient's mouth, you know how your end result will look like. And today there are so many apps, there are so many procedures which are available. If it's a CBCT, if you have planning software, we have 3D implant software, so it makes things easier for us. Proper planning and radiographs and CBCTs. The third one is the treatment options. You have fixed and removable options when you are doing implants. So the patients have to be well informed the pros and cons of the removable and the fixed implant procedures, what we are planning to do. Planning and execution, whether it is in local anesthesia, general anesthesia, sedation. So all these factors have to be taken in care of. The third most important is the biological factors. We will talk about it in detail. The first one is the stability, then the perfusion, suturing and closure without tension, and fourth one is the PRF, platelet-rich fibrin. Coming to the stability of augmented site in GPR applications during healing is an important factor for achieving success. The initial blood clot formation and stabilization of the graft particle will result in predictable bone formation. Although barrier membranes will cover the augmented sites and exclude epithelial and connective tissue cells from the regenerating bone, additional tools are needed to provide the stability and also to increase the resistance of the augmented site from the flap, lip, and masticatory forces. The membrane fixation systems can be used to secure resorbable membranes effectively. By using pins and screws, one can stabilize the membrane to the natural bone to prevent migration of the graft and soft tissue invasion. So this is very important, stability of the bone. You have to keep the bone in place when you expect it to grow. As simple as that. So the stability is very important. And nowadays you have sets, pin screw sets, you know, tiny pins which you have just hammer in and it works perfect. You can keep it, leave it in because they are Titan materials. If not, when you're doing a two-stage procedures, anyhow, in case of reopening and placing of implants, you can easily remove them. So stability gives a very predictable result, if I may put so. Perfusion. The primary source are the cortical and the cancellous bone. The secondary source of the transplanted bone cell is introduced into graft site from the periosteum, so the soft tissue. Therefore, minimally invasive flap designs are very important. Try to avoid vertical incisions. Those days are gone. Always try to avoid vertical incisions. Try to avoid crystal incision. Place it more palatally. If you would like to have a closure, even when you are doing vertical augmentation procedures or putting in umbrella screws, it is very important that the crystal incision is not placed, because then you are sure to have adhesions. Just by following small steps, whether it's the flap design, the suture material use, closing without tension, all these help in giving sure results and avoid adhesions of the soft tissue. So suturing the flap without tension plays a very important role too. Platelet-rich fibrin, this works wonder. I'm using it past few years in my practice, and I am really wondered involved with this method, because there is so much of less of patient morbidity, pain, swelling, and you get wonderful stabilized results. What is platelet-rich fibrin? PRF or LPRF, there are so many different varieties now, LPRF, APRF, is nothing but it's a second generation PRPs where platelet and leukocytes are present in a complex fabric matrix to accelerate the healing of the soft tissue. It is something like a biological bandage, if I may say so, you know. So the indications is everywhere. You can use it with augmentations, you can use it as socket preservation procedures, you can use it in after removal of wisdom teeth, you can use it as as a plug when you do nerve lateralization. So it is used everywhere. To obtain PRF, required quantity of the blood is drawn quickly into the test tubes without any anticoagulant and centrifuged immediately. The resultant product consists of the following 3 layers. You have the topmost layer consisting of platelet-poor plasma, then you have the PRF clot in the middle, and the RBCs at the bottom. The PRF available is as a fibrin clot, as you can see in this picture, and you can make it in plugs, you can make it in membranes, and it is very rich in fibronectin and vitronectin. It has bioactive molecules like PDGF, VEGF, BMPs, which is required for bone regeneration or for healing of the tissues. So this is the picture where we removed the tooth. It was a tooth with a radicular cyst, and one can see the defect, the missing buccal bone, and I usually tend to perforate my site. And you have the mineral material. Here I have used xenograft, and when you mix it, you can have something called as a sticky bone, which is very malleable. It's like a clay you can play it with, and I have placed it onto the area and seen to it that the nerve is taken care of, and then you place the membrane, and after 4 months, voila, you have beautiful bone, and you can place wonderful bright implants, and you can see the whole buccal bone here is beautifully formed. You know, you have a really good margin after placing the implants. Post-operative care. Post-operative care plays a very important role after the surgery. Once the patient leaves your clinic, leaves your hospital, he's on his own. So it's very important that we tell the patient to take do's and don'ts are very important. Antibiotics. I personally give antibiotics only in case of risk patient. Risk patient are people who smoke, the people where there is already a periapical infection, with patients with endocarditis problem, patients with heart valves. So all these, in all these cases, I tend to give antibiotics. Pain medication is very important. We have to tell the patient that you have to cool the region. There is rest and no strenuous activity for the coming days. I'm very particular about the post-op checks in my patients. After the surgery on Friday, my whole appointment is just the checkups, which I do for the number of patients I have operated in the particular week. And after 10 days, we do another checkup. If the sutures are non-resorbable sutures, then I tend to remove it in 10 days. Complications. I think everybody has at some point of his or her career gone through complications. One would lie when they would say we just have wonderful cases which heal without issues. Whatever the reason may be, there are complications. The important is how do you handle complications? Yeah. So it is very important to know that some things have to wait and watch, and some things you have to intervene before it really becomes a risk issue. The early complications include the wound dehiscence, membrane, and graft exposure infections, with the most common complication being wound dehiscence. So wound dehiscence usually occurs in the picture too, as you can see, when you're placing bones. Yeah, it's an autograft, allograft, whatsoever. So it's very important that you round off all the corners. And I usually have learned it in my career doing it past 10 years that I tend to place a resorbable membrane if the gingiva thickness is not as expected. You know, there are people who have very thick gingiva. In that case, it itself takes care of. But in cases or in patients where there is very thin gingiva, where there is very thin mucosa, then it's very important that one places a resorbable membrane. So prevention is better than cure. So take care as much as you can, and so that the complications do not occur. Patience from the patient and the surgeon. Yes, it's wait and watch game. Absolutely. There is not much you can do. You can just tell the patient, take care of yourself, antibiotics, keep the area clean. I use Blue M. Blue M is an oxygenated gel with honey. So it helps in revascularization of the tissue, which works really wonderful. So yeah, that's it. the treatment plan of these complications varies on the basis of the extent of the exposure. If it is small, no surgical correction is required because the granulation tissue that forms will promote the healing by secondary intention. A granulation tissue formation process lasting over 2 weeks may require refreshing of the epithelial wound margins with a diamond bore. So what I use, as I told you, the oxygenated Blue M gel, which really works wonders. A large dehiscence has to undergo a surgical refreshing of the wound and resuturing. There are cases where you have to redo the procedure from the beginning. So in that case, unfortunately, you have to take care and see to it that the wound or the problem is solved as soon as possible. Complications may be prevented by careful preoperative assessment and planning which augmentation procedure suits the patient. Always custom plans, that is patient-oriented. Minimally invasive flap design and careful reflection. Appropriate instruments and proper suturing. So the proper armamentarium really plays a very important role, whether it is your periosteal elevators to the suture material you use. Sensible temporization with appropriate modification, rebasing and relining, and delaying the use of removable dentures until 2 weeks after surgery. Coming to the cases. So this is the first case where we can see that the implant is being seen on the buccal side and there is missing buccal bone. So in this case, I did a bone augmentation. So there's a soft tissue defect. As one can see, the patient was very young when this implant was placed. And then it was a difficult go because of the missing bone. And then we did a multiple stage surgery here where we placed implants. In the second step, coming to the second case, one can see the sinus floor and the residual bone level, which is very less. And here vertical bone augmentation was done. This is the allograft, and the vertical bone, this is the maxillary sinus, because here external sinus lift doesn't make sense because we tend to build the bone then in the sinus, which is unfeasible in this case. Coming to the sinus lifts, this is a procedure which we do day to day in the missing maxillary posterior region. In this video, one can see a wonderfully elevated maxillary sinus membrane which dances when the patient breathes, I may say so. It is a joy to see a beautifully elevated membrane. And another case where we do a maxillary sinus elevation, external sinus lift, and I was brave enough to place all the 3 implants here with a residual bone of less than 1.5, but everything went on fine. The fifth case is where we placed bone, even though there was a maxillary sinus opening. It is my technique. I'm working on the publication, so I'll be keeping you all informed once the paper is out. Then we have full mouth rehabilitation cases. This is a case where the patient had undergone multiple periodontal surgeries, but unfortunately without any success. So we decided to remove all the teeth, place the implants, and then he got a full arch, full mouth rehab. Last case was also a periodontal surgery case where we placed implants and we did all on 4. And here, as you can see, this is the patient's own bone, which I mix or make tiny and then mix it with the xenografts. Then the patient got final ceramic bridges. So successful augmentation and implantation depends on the custom-made patient plans, the analysis and planning of the procedures, treatment modalities, and regular checkups. So it's very, very important. And all these things done together in the right time at the right place leads us to successful augmentation and implantation. Thank you. Thank you so much for listening to me, and keep following us on AAOS.